I'm appreciated for this kind of discussion because each speaker has his own specialty. I think it's really nice to have different specialty into one section in order to express their own opinion. I have one question for Dr. Higashira. My question is that we all know, I'm also a surgeon, so we all know your study on JCOC. And my question is that why in JCOC 1109, the next trial, we put stage 1B patient into the Shuiyang study? Because we all know that stage 1B, your result is excellent. You might dilute the difference. Statistics difference. So why we put stage 1B into the trial? Thank you.
Actually, they in the study network 1109 stage 1, we use staging by UICC. So it is 1B means T1B is not plus or it is not negative. For study for stage 1A, we think it is enough for only surgery. But otherwise, so we think it is necessary for advanced or neoadvanced therapy. So in 1109, we included the stage 1.
Chinese OK 我有一个问题想问台大的陈医师，你的第二个 case 后来的口腔癌治疗非常好，但后来的 failure 是食道癌转移，是不是？我记得 second case 对，就是 metastasis， 它 lymph node 不止的 lymph node 就有 metastasis recurrent。那我的意思是说，如果这 case 重新来的话，你会先治疗口腔癌？然后 follow by 食道癌，还是说你会先治疗食道？因为我的想法是这样：如果这个食道癌 clinical 已经是蛮 advanced， 其实它非常容易 distant meta。食道癌比口腔癌更容易 distant meta， 是吧？所以这是一个很难的 issue 了。我是说，回过头来看，如果这个食道癌在 clinical lymph node 已经是 positive 的，你会先治疗食道癌，然后 follow by follow by 他的口腔癌，还是说你还是会维持原来的这样？
可以用中文回答。
中文比较。
因为那个病人他是不想开刀的，对啊，但是这个就是病人意愿。但是如果是以团队医师或者说收科诊疗现行的单案来说的话，那个当然可能病人的预后可能是取决于 index cancer 啦。这个病人他的 index cancer 可能就是食道癌，因为 T4 的mixed top palate cancer。People NGO 其实可能还算不错，所以它 index cancer 其实是食道癌，所以我的想法是我从个人的想法啦。那对于这种 index cancer 的话，那是不是应该是以index cancer 它的积极治疗为主这样子？我自己的想法是这样，所以可能对于食道癌的话，我会认为他们是需要因为跟 CCRT 再接 curative surgery。那只是说手术跟食道手术跟那个口腔癌的手术要怎么去结合
？I wish to translate. But if I'm wrong, please. I apologize for that. I'm a radiologist. The question from Professor Lee is for case 2. Actually, the problems in esophageal cancer is more advanced than oral cancer. Why if And the outcomes is that oral cancer is controlled. However, unfortunately, this patient advanced distant metastasis caused by cervical cancer. That means esophageal cancer treatment is failed. Okay. But the treatment plan is like that. Oral therapy comes first, followed by cervical cancer successfully, right? So if the story can be repeated again, he would like to ask Dr. Chen, will you change to become cervical cancer treatment comes first, followed by oral cancer? And the answer from Dr. Chen is yes. But from a treatment point of view, doctors must respect the decision from patient and his family. And the patient decides to choose organ preservation instead of surgery. So they, after agreement, they choose this treatment regimen. And she knows the treatment regimens are not 100% fit, the guideline from the hospital. Okay? But from doctor point of view, their team respect the decision from patient and is there any question?
Thank you for the great speech. And I have a question for Dr. Egashira.
Can you introduce yourself?
I'm Dr. Wang. I'm a radiation oncologist from Tzu Chi General Hospital.
Okay.
And in comparison to NCCN guideline, which set neoadjuvant chemoradiation as a standard treatment for locally advanced esophageal cancer, and I've noticed that in your presentation, the Japanese clinical trial you mentioned, there's only one trial has included radiation as a neoadjuvant treatment. That's one of the 3 arms in that clinical trial. So, is there any special consideration about the radiation use in the esophageal treatment consideration? Is that because radiation might induce too much side effect that will complicate your surgical resection, or reasons other than that? Thank you.
Thank you. Study, in my opinion, so there are 3 arms: cisplatin 5-FU, docetaxel, cisplatin 5-FU, and cisplatin 5-FU plus radiation. And
他叫我放他的
if
字，
you use
等一下哈，
if you add radiation with docetaxel, cisplatin and 5-FU, so it is for modality therapy.
不知道放出去会怎么样？
Patient
是他
cannot
没错，
tolerate, so many toxicity
跟上面
during the
对
therapy.
吗？
再往上，
So you cannot complete neoadjuvant therapy.
这里已经把它播出来了呢，
等一下再播好了，找到再播好了。
他会录哪一个？他应该还是录这个。
We have
播这样，我觉得连续录比较好，这个后置都可以。
systemic
overall stage 0 to stage 4. So I think you're right. Nationwide data is a little bit lower than Jacob there.
But still,
Okay.
But, all right, that's to simplify this. Our stage 2 esophageal cancer, the median overall survival is 21 months. Stage 2, can you?
How about 5 years of this? We don't know the MSD.
excuse me, 21 months. 21 months, so how can you say 5 years? Okay.
Yeah, I have the.
I think it must be less than 15.
Less than 15, yeah, I know. Okay, I want to say one more thing. Okay. We Japanese surgeons have confidence to the lymph node dissection. There are no need to do the neoadjuvant radiation for the prophylaxis for the lymph node metastasis. You understand what I mean?
Surgery.
Surgeon, I think I should respond for this, but since I'm a relatively young generation, so I'm not going to respond for those old data from long time ago. That's the first point I want to make. The second will be actually we are learning from both Western and Japanese students. Actually, we do visit like Kyushu University. I have been there twice, so I know exactly what they are thinking and what they are a little bit worried about the side effect of radiation, which might blur the surgical dissection plan. Actually, I am quite confident to tell you that actually both sides, the Western and the Japanese, they all have their thinking process and the real logistic and their works. But that's why they conducted the 1109 next trial to answer this question. However, the carcinogenesis, the patient condition, and also technique, and also patient their will is not the same. So, in my conclusion, now Taiwanese aesthetic surgeons are trying to do a better and better. I think maybe if you really want to see the result, I think we can do much better than our older surgeons. So that's my answer.
Okay, I have 5 year survival data. The stage two. With esophageectomy, the 5-year overall survival is around 40%. 40% for stage 2. And with esophageectomy for stage 3, the 5-year overall survival is only 20%. Is it?
We have 60 and 40.
So we have 40.
Okay.
Oh yeah. Sorry. I'm talking about based on the Japanese criteria, Japanese classification of the stage. We don't use any TN. I'm don't using the TNM stage. Yeah, sorry.
I think we have plenty question and many things to learn. But considering our stomach, it's closed right now. But I hearing encourage everyone to discuss, to continue your discussion during lunch and during dinner or even in the afternoon. Thank you very much for visiting and